Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the October 30th issue. Considerable data exists that PET scanning has greater sensitivity and specificity to SPECT in the detection of coronary artery disease. However, over the years, SPECT has improved. There's been ECG gating and there's been attenuation correction. And so the question exists, how does the latest generation of SPECT compared with the most efficient technique for PET, which is rubidium-82 PET. And so we have a paper in JACC that actually is a meta-analysis done by a group of Canadian physicians on the latest data. And they took studies that compared the accuracy of rubidium-82 PET with standard sestimib SPECT techniques with attenuation correction and ECG gating against invasive coronary angiography. And what they observed was that, in fact, even with the new technological advances in SPECT, that PET was still superior. A sensitivity of 90% versus 85%, a sensitivity of 90% versus 85%, specificity of 88% versus 85%. And so clearly PET remains the more accurate technique for the detection of coronary artery disease. Nevertheless, we've known this for a long time, and most physicians have judged that the increment, the magnitude of the increment of PET accuracy was not worth the additional expense and the complications and complexity of obtaining PET scans. So that even with this enhanced accuracy, at the moment I think most people would still feel that SPECT is the primary modality for diagnosing coronary artery disease. However, there are new PET tracers coming, and there's no question that it will become increasingly difficult to get SPECT tracers with molybdenum becoming much less available to hospitals. So we'll have to see what the future holds, but with these new tracers and with less SPECT availability, perhaps PET has reached the point where it will become the dominant technique for diagnosing CAD. It's clear that endothelial dysfunction plays an important role in heart failure. However, it's not been studied as to the role of endothelial dysfunction in heart failure with preserved ejection fraction or normal ejection fraction. And so in a study from Japan that's about to be published in JACC, these investigators looked at that very question, and they had over 300 patients with heart failure and preserved ejection fraction. They studied endothelial dysfunction by peripheral arterial tonometry, and of course had good echocardiographic data to identify the patients with preserved ejection fraction and diastolic dysfunction. Now there were 59 events, and what they found that there was clearly an increase in the hazard ratio for having an event, a heart event, in patients who had heart failure, preserved ejection fraction, if they had endothelial dysfunction. When they did receiver operator curve analysis, the statistic was also increased when endothelial dysfunction was added to other risk factors. So we have another risk factor for events in patients with heart failure and preserved ejection fraction. Whether or not this is a clue to a therapeutic target remains uncertain, but certainly an easy risk factor to determine, and one that might help us be more aggressive in treating our patients with HFpEF. Although it's known that patients who respond to cardiac resynchronization therapy have a less propensity for arrhythmias, it hasn't really been studied as to whether or not this relates to ventricular tachyarrhythmic events. And so the investigators from the MADE IT CRT trial did a sub-study that looked at this very question. They looked at whether or not CRT-D with defibrillators reduced the first episode of ventricular tachycardia, and also whether it reduced subsequent or recurrent ventricular tachyarrhythmia events. And what they observed was really interesting, a bit perplexing. They found that in fact CRT did decrease initial ventricular tachycardia events in patients with left bundle branch block, but not in patients who did not have left bundle branch block. What was even perhaps a bit more confusing than that, when they looked at recurrent events, then CRT did not reduce recurrent events in the patients with left bundle branch block and actually tended to increase VT in patients without left bundle branch block. So a very mixed message. CRT is effective in reducing ventricular tachycardia, but primarily in patients with left bundle branch block, and in fact, in terms of recurrent events, might actually be a bit deleterious in patients without left bundle branch block. Now, I'm not clear myself on the take-home message from this, except to say that in those patients with CRT, we clearly have to be vigilant in terms of ventricular arrhythmias, and if we see any tendency toward ventricular arrhythmias, have to be very, very aggressive with anti-arrhythmic therapy, be it drugs or even ablation. So really interesting articles in the October 30th issue. I hope you enjoy reading them.